We appreciate you all being here. The ones that are here in person that are eating the brownies and the cookies, you know, us heart patients, we get to that before the vegetables. Anyway, and we also welcome those people on Zoom. It's nice to have you all here. This is our seventh presentation in joint participation with Eisenhower Health. My name is Bill Stark, and I'm the president of the Coachella Valley, Mended Hearts of Coachella Valley. And our whole purpose in life is to, in Mended Hearts, is to try to offer hope and encouragement to those people that are heart patients or their families, and then offer these kind of educational forums. And so we've partnered together with Eisenhower Health to use all of their social media stuff, and then what we send out on emails and flyers and stuff around the hospital so that we can get more participation in that. And we've had doctors and surgeons and all kinds of nurses and everybody to come talk to us about heart stuff, how to live with it and how to be better about it. So that's what we're here tonight. Excuse me. For those people on Zoom, if you have a question for one of the presenters, and there are two of them tonight, just put it in the chat room and we'll get to you. We'll have a, excuse me. You can tell I had one of the cookies. Excuse me. I cannot get the water, thanks. So we'll have a roving mic here and there, and we'll try to answer the questions at the end of the presentations. A little bit of hoarse too, sorry. Anyway, so tonight our first presenter is going to talk about the level 4 trauma. This happened in a new center here in Eisenhower Health, and they've taken on that responsibility here in the Coachella Valley. And we're pleased to have Brody Eick. Do I pronounce it right? Eick, Brody Eick, who's he's got so many things behind his name. As you see on the board up here, it would be impossible to go run through all of those for sure. So we know that he had been around Loma Linda for a long time, worked there, and he was here before, came back to the desert to really initiate the level 4 trauma center here and get it going. So please give us the good welcome to Brody Eick, please.
All right, thank you. So like Bill said, my name is Brody Eick. All of these little letters just mean that I've been a nurse for a very long time, pushing almost 20 years, which I guess when you think about it isn't that long, but when you look at nursing right now, it seems like we're, you know, when you're hitting that 20 years, you're ancient because we have so many new grads. I'm originally from Ohio. I come from the Midwest, East Coast. I've done trauma my whole career in big level 1 trauma centers, worked in the south side of Chicago for a long time, in Baltimore, at shock trauma. It's kind of been a passion of mine. I fell in love with it very early on because I figured it's one of the only specialties that someone can come in truly broken and you can fix them and send them on the way right away. You know, you see people come in and their absolute worst moment of their life when they kiss their loved one, they weren't expecting it, they go out and they get in a car accident, and you know, it can be really tough on families too. So I came out here, I just started back here January 16th. I had been asked to interview and came out to start this trauma program. And it was very exciting for me. I was an ER nurse here as a travel nurse about 8 years ago with Kathy. And I always said, you know, there's a huge gap in trauma in the Coachella Valley. You have Desert Regional, which is a good trauma center. They were the only trauma center at that time. And you think about it, that's the only trauma center from Loma Linda and the Inland Empire area all the way to Phoenix, Vegas, and that huge, vast area. If anybody gets injured, there's one place for them to go. And depending on where you were, you either went to Phoenix, Vegas, or you would come all the way over here to Desert Regional. So when they asked me to come out here and you know, I was able to take this position, I was really excited. So real quick, I'll give a little background on, there we go, on kind of trauma in general, right? So there's 4 levels of trauma centers. You have your level 4, which is currently what we are, and your level 1 is the highest. They're differentiated really just by the amount of resources that are available around the clock. So your level 4 trauma center, typically, it's actually very new to California. You would typically see that in a very rural hospital where you really just wanted to have your ER physicians be trained in how to stabilize and ship out, right? Your level 1 trauma centers, those are the ones that are, you'll have every specialty. You have cardiothoracic guys, plastic surgeons, hand surgeons, be able to re-implant, meaning like if there's a traumatic amputation, they should be able to reattach that extremity or that digit. They have to have a residency program and they have to have research. When you have your level 2 trauma center and your level 1, clinically they're identical, but your level 2 doesn't have to have that robust research program. They also don't have to have that residency program. So it's kind of the only difference is the money that you want to put into it. Level 1s are usually also affiliated with some sort of university. Like you've got Loma Linda University Medical School. RUHS is affiliated with UCR, University of California, Riverside. So usually you have something like that. And as your level gets higher, you have more responsibility for those programs. So one of the driving forces for Eisenhower was we got our level 4, and in the state of California, you have to be designated by your county EMS agency. So where I'm from in the state of Ohio, that we don't do that. We just use the American College of Surgeons for a verification process. Out here, the RIMSA, which is the Riverside EMS agency, so your AMR, all of your CAL FIRE medics, all that stuff is actually governed by a county agency. And so they came in, they designate you as a trauma center. They say, okay, now that you're a level 4 trauma center, you can start receiving EMS traffic with trauma patients. Someone falls and hits their head, they're on a blood thinner, and you have concern for bleeding inside the brain, or they fell and they have a obvious deformity to their leg or their arm. Now we can technically accept that patient, treat them, stabilize them, and then you become verified by the American College of Surgeons. So it's 2 separate things. They currently do not verify level 4 trauma centers. So they, right now we're just designated by RIMSA, but the goal will be that within a year, and I'll touch on this, is that we'll go for our level 3, which will then be verified by the American College of Surgeons. And so then that puts us in this massive group of trauma centers, this huge network that we can pull from. Our data, all of our like the data that shows how many falls we have, what our penetrating trauma, all that stuff, all goes into one humongous national trauma database. And then that's what actually is used to make laws like the seatbelt, the click it or ticket campaign, drunk driving campaigns, gun control, any of that stuff. They look at this trauma data, and that is what supports legislature for these laws and these new things. And we actually have, it's the Automotive Association of America, not AAA, but there's that does all of the national like traffic standards and stuff like that, is actually one of the governing bodies that does all of the coding for traumatic injuries as well. So they look at that data and they look at what, so we have to actually put, did airbags deploy, how much intrusion was involved. So there's a lot of data that goes into trauma as well. Once you are verified, we get 3 years, a 3-year cycle that you have to, you have that 3 years to make sure that you maintain, or you can step up your level at the end of that 3 years. So right now, we are currently October 7th, 2022, we went live as a RIMSA designated level 4 trauma center. Once we got that, we saw our volume increase a little bit, because now the paramedics were able to bring the patients that they had always wanted to bring to us to Eisenhower. We have a community out here that likes Eisenhower, loves Eisenhower. We give great care, and we've just never really been able to offer that service of if you fall and you fracture some ribs, or you have some sort of traumatic injury that you would have to go to Desert instead of coming here, you can now come here, right? We're able to receive these trauma patients from the pre-hospital setting. Our primary focus still is to assess, stabilize, and if it is a really complex trauma case, then you still will have to go to Desert Regional. That's kind of mainly because they are the level, well, they're now a RIMSA level 1, even though they're by the College of Surgeons still a level 2. It's where it gets confusing, but they have 24-hour coverage for neurosurgery, cardiothoracic surgery, anesthesia, these 24-hour. So if anything were to happen in the middle of the night, they can handle it, right? Currently, we don't have to have that 24-hour coverage, and we currently don't have 24-hour coverage. We have neurosurgeons that will answer the phone if there's an emergency, and they can do, but they don't have in-house 24-hour coverage as where Desert Regional is required to be a level 1 trauma center. So when we do transfer, and I have a slide on that too, but it's not necessarily about the quality of care you're going to get. It's just more about the safety and the availability of the resources. So that's why we have to develop these transfer criteria. So any pediatric patients we look at, they will go to Loma Linda. Riverside University Health System is actually developing a pediatric trauma system as a trauma program as well right now. Once they get that up and running, since they are in our county, that would probably be our pediatric transfer center. You know, Loma Linda right now has kind of been the gold standard for peds. They still probably will be for a while, but once RUHS really gets the wheels going on their peds trauma program and they've got it up and running, then it would be a lot easier for us county wise, and it's a little bit quicker to get to there from here. As far as burns, any burn patients, we currently have a transfer agreement with UC Irvine. Arrowhead is the burn center that's closest to us. It was kind of more the decision. I've kind of questioned that a couple of times, and it was more that Arrowhead just kind of drug their feet on getting the agreement signed, and UCI was very quick. And so we have a really good relationship with them. We've got it's outlined that our airships and our air EMS groups, Mercy and Reach, they are very quick to respond if we need to fly a burn patient to Irvine. It's unfortunate because, it's a pretty good distance if your family member is burned and you have to go to them. But, UC Irvine is a phenomenal burn center. So, you're going to get really good care if you unfortunately have to go there. Currently, what we can do is we admit minor injuries, isolated neurological and orthopedic injuries. So hip fractures, femur fractures, humeral, like arm fractures, clavicles, ribs that don't have pulmonary contusions, small head bleeds can stay here. If there's a concern for polytrauma, meaning there might be something in the gut, your liver, your spleen might be injured, as well as a fracture somewhere else, we're probably going to still recommend transfer to Desert Regional, just because we currently do not have we don't have a neurosurgery group in-house yet. It's a negotiation. So once we have, so our general surgeons are kind of taking on the brunt of having to admit trauma patients if they're not used to admitting. And same with our hospitalists, as where once we have these trauma surgeons in here, they are very accustomed to traumatic injuries and the sequela that can happen, and they will be much more comfortable admitting these patients. So that's kind of what's exciting about as we progress and we get our trauma surgeons here and involved, is we'll be able to keep even more patients here at home with us and the care that we know that we can give them. So they will be our admitting service. We're going to tentative of May of 2024 is when we'll push for our level 3. We've got a few programs that we have to get up and running before we can make that happen. And then we're going to go for our ACS level 3N, which is a new verification that the College of Surgeons has just started doing. And what that means is that it shows that we have the capabilities to manage any neurosurgical issue. So we already have a robust stroke program. So we already know how to handle a lot of neurological issues. We're not naive or new to, bleeding inside the brain and how to handle that. But now this would step it up even further with the trauma, because traumatic brain injuries can be very time consuming, very costly to patients and their families. It can be a very long process for recovery. So this would entail inpatient rehab. There's a lot of programs that would go along with that. and we would be able to keep any neurosurgical patient here at Eisenhower instead of having to transfer those to Desert Regional. So that'll be a really good kind of step for us. JFK currently, they're going for their level 3 status, but they don't have neurosurgery. So that would be a difference of, they could handle the same type of orthopedic injuries and stuff like that, but any neurosurgical would have to come to us. We'll be able to accept higher acuity patients in general, but we still will have to, just because we are still level 3, certain really highly complex trauma patients will have to go to Desert Regional until we progress our level even further. But the nice thing is every 3 years, we can, as long as we're meeting the requirements and we can kind of keep the ball rolling, then we can increase our verification and our designation to the point that we would have 2 fully functioning comprehensive trauma centers here in the Coachella Valley that would be able to manage the abundance of population that we have. You think about it, Brett and I were talking, there's a thing in California, they say for every 500,000 permanent residents, you can have 1 level 1 trauma center. And so they will look at it and they say, well, there's only like 400 and some thousand people that live in the Coachella Valley permanently. And I said, well, I'd like to know when you ran that number, because over COVID, you guys, everybody that lives here, we've seen the traffic and how many people have moved out here. It's just outrageous. But I said, what about the 8 months out of the year that we're like 1.5 million people? I said, those people get injured as well, whether there's, they're here just for the winter or whether they're here year round. Why should that make a difference? And so it would be really nice once this we've really worked to collaborate with Desert Regional and JFK to kind of establish what we're calling, it's kind of like a Coachella Valley trauma system, to where we're working together and we're collaborating more. There's no competition between the 3 facilities. We want to make sure we're doing what's best for our patients and we're getting them where they need to go. And we're also doing, respecting their wishes as well. So if people want to stay here, as long as it's something that we can handle by regulations, then, now they can stay here at Eisenhower. Heidi and the Desert Regional group have been really good about kind of opening the conversation with us. And so we can talk about doing regional education. So now we're trying to incorporate all 3 facilities, the nurses from all 3, bringing them together and having a mixture of JFK, Desert Regional, and Eisenhower nurses doing trauma education together. So it's more standardized across the book, right? We're going to do, looking to do big disaster drills that are regional. So, we got Coachella starting this weekend. We got 3 weekends where so many people are there and everybody's having a great time, and some are under the influence of things. Most probably are, and bad things can happen. We all know that, right? So if something major were to happen at Coachella or the new Acrisure Arena, we want to be fully prepared, or, God forbid, a huge earthquake, that we can disperse patients safely and appropriately between all 3 facilities. And we know what our capabilities are. And so we're doing a lot of collaborating, and we're going to open that up as a thing. And we're going to start talking to the community and trying to get the community involved so that everybody feels really comfortable with the care that they're receiving and feels comfortable with where they end up as a patient. So they understand why they kind of have to go where they want to go. So this is, I already kind of talked about this, but why do we have to transfer? So currently, we don't have, we're getting the trauma surgery group in here, but currently we don't have that. So it would be, this is one of the major things. They have trauma surgeons 24-hour coverage. They have 24-hour neurosurgery coverage. They're specialists. Now, the American College of Surgeons kind of puts out a Bible of, and it's called, it was the Orange Book. It's going to be the Charcoal Book as of 2023 in September. And you'll hear people talk about it like, oh, well, what's the Charcoal Book say? What's the Gray Book say? And if that is the Bible, and you can take that to your administrators and say, if we want to be a trauma center, this is what we have to do. And it kind of makes it nice for me, because I can say, if they're like, well, I don't know about that, like, no, if it says it right here, this is what we have to have. And that they just put out now that it has to have 24 hours a day, 365 day a year coverage with no gaps in coverage to maintain your level 1 status, which a lot of trauma centers before, there was four specialties that you had to have, and that was it. It was like orthopedics, neurosurgery, general surgery, and ER. Now there's about 15 to be a level 1. So those other big level 1s that used to be able to like outsource, or Harborview up in Seattle, massive trauma center, but they used University of Washington's cardiothoracic surgeons. So now they said, nope, you have to have your own. And so these places that have been long-standing trauma centers are having to really beef up their recruitment and establish transfer agreements and like agreements to get people to come in. So it's really interesting how trauma care can change. They have this big pendulum and it'll swing one way. Right now it's on substance abuse and PTSD, which is a good thing, because we all know that I've experienced as a nurse traumas where they come back and you see them later and they look great, and then unfortunately a year later they come back in with like self-inflicted wounds from, because they just, the mental anguish of what they experienced is terrible. And we realized as a trauma community that we were kind of dropping the ball on that we fix you, but then we say, here, go, and now you have to deal with the aftermath of what you've experienced. And anybody's been in a really bad car accident knows that that's pretty traumatic, and it gives you anxiety. And some of these people that have, were near death. This was a young 19-year-old boy at the time and came back at 22 years old, and he was our success story. And then he took his own life because he just couldn't, he was having night terrors and we didn't have the follow-up. So now the College of Surgeons has recognized that that's happening so often that now we screen for PTSD. Every single trauma patient within 30 days has to have a screening. We have to screen every single trauma patient for alcohol and drugs of abuse, whether you're 3 months old or 130 years old, you get screened. And if for some reason you test positive, whether you just had a glass of wine and you never drank before, you're going to get, someone's going to come to you and just talk to you about alcohol and substance abuse and see if there's something we can do to help if there is a reason that you would need help, or to prevent someone going through withdrawal. Because we get traumas that maybe we aren't able to talk to them because they're so sick, and then they're in the hospital for a week on a ventilator, and we don't realize that they are a daily bottle of whiskey drinker, and they start going through withdrawal, which can wreak havoc on your body and really could kill you. And so we start seeing these signs of withdrawal. And so it's supposed to help us as a community really recognize these things. And it's interesting because at first it's kind of like, oh, it's just so much more work. And then when you really understand why they push that, it makes sense. And you understand that these are things that, so everyone gets screened. We currently have a really nice ICU, critical care unit. We don't have a trauma specific ICU that we will be opening soon. It's required to have a trauma surgical critical care unit to be able to keep certain high level traumas. So that's why Desert Regional does have that. So that's why some really sick traumas will go there. So hopefully over the next year or so, we will be able to have that open. I know the ICU team is already working on that, and we'll be able to start admitting more critical care patients. Real quick, sorry, I can talk forever, so I get very passionate about trauma. So this is our trauma field triage. The way it works is every ambulance in the state of California has to call a base station, which many hospitals are base stations, but if you're like Desert Regional was technically the trauma base station for the Valley. So they could be 4 blocks away from us, but because it's a trauma, they're going to call Desert Regional and say, hey, this is the patient that we have. And then they have an MICN, which is a mobile intensive care nurse. So that nurse sits there, answers the phone, has certain protocols, and based off of, and I have a little picture of it on the next slide, but these certain criteria that the American College of Surgeons, our county and our state has provided, they'll say, yes, you can go to you can go to Eisenhower, or no, you need to come to us. And so that's kind of, you may literally be around the corner and get injured, but if it's a pretty bad injury, they're going to bring you to there, because instead of coming here, us identifying these really bad injuries and then having to transfer you again, one, it's financially, that's kind of, because then it's a EMS run and stuff like that. But it's also better to get you where you need to be and as timely as we can. Right. And then the field triage, like I said, this is it here. I don't know if you can read it, but The red boxes at the top are the ones that are life-threatening. So those have to go to a level 1, right? So the top one is like penetrating injuries to the head, neck, torso. I mean, if you get shot, stabbed, any kind of spinal cord injury where you have loss of sensation, a skull deformity, 2 long bone fractures, meaning like your femur and your humerus, or both femurs. We get people that are in car accidents and it gets pushed in and it breaks both of their legs. And those, because you can legitimately bleed to death just from your femur, because you can put about 4 liters of blood into that compartment there, if just by one fracture. So that they take that really seriously. If we have to put a tourniquet or constantly hold pressure and it continues to bleed, you're going to go to Desert Regional because of the vascular surgeons. And then the one on farther is like if you have altered mental status or your vital signs. Now the yellow ones are ones that are, okay, you have a risk for serious injury, but you're probably not life-threatening. And those are the ones that are probably going to be able to come to us. So a partial or complete ejection, intrusion, you could be in a car accident if someone else dies in the compartment with you, but you might not really have many injuries. We look at that as a high enough impact to kill someone, so that's, you have a pretty high risk for potential for injury, so you're going to be a trauma. So you're going to come, but you could come to us. It doesn't mean you have to go to the level 1 trauma center. Usually it's any fall from height greater than 10 feet. So if you fall off your roof, and it's more than 10 feet, you're going to be a trauma activation, just so we can rule out any kind of pelvic fractures, spinal fractures. One thing that this here, so these are our trauma activations. So you can see when I first came in, there had been a couple interim directors here. And when I came in January, I looked at the criteria that they had put in place for how many people, what we were activating for our traumas, and it was a little over the top. So they were activating anything within 2 weeks of arrival. So you could have fallen and bumped your head if you take an aspirin, but be completely fine, and then come in for like, oh, I'm a little stiff, and they would have activated you as a trauma, which as soon as you get activated as a trauma is a, there's a fee assigned that comes along with that. And it's all these resources, right? You bring all these doctors, these nurses, X-ray, CT. The standard, which we've kind of changed it now to, is 72 hours. So if you fall or you get into a car accident within the last 3 days and you're having symptoms, we can activate you as a trauma. Otherwise, we'll still work you up in the ER, but we're not going to activate you as a trauma and because truly when we activate you as a trauma, we have to, your clothes have to come off because we have to do a full complete body scan on you. It can just be a lot. And 2 weeks ago, if you were able to make it through 2 weeks, you probably don't need that kind of dramatic assessment, right? We'll still scan you. And if we find an injury, we can do what we call a trauma consult, where we get our trauma surgeons to come in, and they'll come in and they'll manage that injury. But we don't have to do a full trauma activation. Since we made that, our activations have went down. We also have implemented something called a trauma CT alert that's pretty new. I've used it at another facility, and it's something that it's starting to get really pushed across the country. So we're one of the few trauma centers that are actually doing this right now. If you're 65 years or older, you have fallen, you've hit your head, it has to have a known head strike, you're on a blood thinner, but you are at your baseline, you're alert and oriented, and you don't have any blatant signs of trauma, like a big, huge laceration, maybe a little bump or a bruise, we're going to do a CAT scan right away. And if your CAT scan of your head is negative, then we'll work you up in the ER like regular, and you'll be able to, go home. If it shows any kind of bleeding, then we would activate you as a trauma. What that's done is it's decreased our activations by about half. And so so we were seeing about 80 plus trauma activations a month. Now we're seeing about 40 or 50, which is on point for a level 4 trauma center. But those extra 40 or 50 people were going to spend 6 to 8 hours in the ER, and they all were getting discharged from the ER. So now what we're seeing is now 2 hours and you're getting discharged, and you're not having to have the trauma activation and stuff like that. So it's really done a lot for our over triage. It's done a lot for the happiness of our patients, because now we're able to get you in. We can rule out anything life-threatening right away. We're still, you're still going to get blood work and stuff. It'll take an hour, 2 hours. And in that meantime, if you develop other symptoms, we're going to be there to monitor and stuff like that. But most likely, if your head CT is negative, the chances of developing a bleed later are very, very minimal. So this is something that's starting to be pushed out across the country. Loma Linda they've started it as well. So Desert Regional we just had a meeting, and I was telling them what we were doing, and they were just like, oh my gosh, that's amazing. So, this is something that we're kind of on the forefront of, and it's really helped us because our population is, in general, median age is a little bit higher than, LA or somewhere like that. So we're seeing that blue is our falls. So our traumas are over 60% falls. That was our kind of bread and butter. And then the red here, the other biggest piece of the pie, are motor vehicle crashes, because we're right by the 10. And then all those other little ones, there's gunshot wounds, assault victims, foot injury, arm injury, stuff like that. There's some other little things in there, but mainly that little green box here too it's just a general trauma, which would be, could be motorcycle crashes, stuff like that. Just depends on how it gets coded when we can track it. But as you can see, falls were primarily our everything. And we were seeing so many, and anybody that came in, and how many people take a baby aspirin every single day, and they consider that a blood thinner. So if you had fallen in 2 weeks and you'd bumped you didn't even require you to have to hit your head. The old criteria just said any fall on any blood thinner, you got activated. And so we were activating people that fell and landed on their behind, but took an aspirin, and then we were hitting them with an active trauma activation, and you had 3 physicians and doing abdominal fast scan and CT scans of your whole body. And so this CT alert has really decreased a lot of that by almost half. So, and we still see some of our patients getting discharged from the ER, and that's okay. We monitor that, because if you're activated as trauma and you get discharged from the ER, then it usually means you probably didn't need to be activated. But we actually get a certain percentage that we can meet before the College of Surgeons would kind of say, hey, maybe you need to relook at your criteria. But yeah, so sorry, that was a lot in a little bit of time. So are there any questions about anything? Yeah. You mean to the level 1? So I would say that we could, in a perfect world, if everything goes well, probably in 4 years, we would be at a level 2, which is the same clinical, a level 1, level 2 clinically are the same. So we would be able to keep every single patient there that we come in contact with. One of the things that it's going to take to get us there is a recruitment. I oddly didn't realize it was so difficult to recruit physicians to the desert, but it is. I thought to myself, I'm like, wow, Palm Springs is beautiful. Indian Wells or Ranch Mirage. But yeah, we've found that it's actually pretty difficult to recruit experienced healthcare providers, nurse practitioners, physicians, PAs, nurses to the desert. So that's going to be a really big undertaking that we're going to have we have a huge orthopedic group already, but we have to have a traumatologist orthopedic surgeon. So someone that has done a specific trauma fellowship. And we find that a lot of people came here because they didn't necessarily, they maybe had done trauma in the past. They didn't necessarily want to do trauma anymore. So now that we are a trauma center, there's some that are very on board, which most of the organization is very happy and very on board. But it will take some recruiting and kind of buffing up our med staff and our nursing staff. So I would say, yeah, because you figure if we go within a year, we go for our level 3, and then it would be a 3-year cycle after that we could go for our level 2.
Nothing on the chat currently.
Mm-hmm. Yes.
You're saying you're looking for qualified people that could be certified to be in trauma. Does the hospital make any effort at all to train in-house doctors right now to be certified to get into trauma?
So question is is the hospital, so I'm just repeating it for the Zoom. So if the hospital would do training for the current med staff to be able to be trauma capable. So that's kind of a tough question, because to be truly trauma trained, you have to go through a fellowship, which is like 3 or 4 years. You can, at a level 4 right now, the nice thing that we have is we have this kind of grace that as a level 4, we're a much higher functioning level 4 trauma center than any level 4 trauma center I've ever even heard of, right? Like most level 4 trauma centers do not have general surgeons. They don't have cardiothoracic surgery. They don't have neurosurgery. They might have 1 or 2 ER doctors at all times. And sometimes they don't even have an ER doctor there 24/7. So those are usually your really tiny hospitals. And we're this massive hospital that has so much to offer. One of the reasons we kind of started with level 4 is get your foot in the door. One of the big things that they look at is data collection. And so this gave us the opportunity to start collecting data, get in with the RIMSA, get our kind of workout. There's a lot of bumps and a lot of hiccups that we're running into. Every day someone will be like, well, what do we do with this? I'm like, oh, I never thought about that. So there's, it's kind of everybody's working together and really working to try and iron out these kinks. But so technically our general surgeons now, because we're not supposed to be keeping those really highly complex trauma patients, could technically manage our trauma patients. And they do. They currently right now, they're the consult. That's who we call for any trauma patient if they need it. The ER doctors kind of run the trauma, the whole thing. If there needs to be a life-saving intervention, our ER doctors are actually probably going to do it first, and then they'll call general surgery. God forbid if we have to do a thoracotomy, which is, if we have to open someone's chest to cross clamp their aorta and save their life, that's probably going to be the ER doctor, because they're right there at the bedside. Once we have trauma surgeons, those trauma surgeons are required to be at the bedside within 10 minutes of the patient's arrival. So if they were to lose pulses and we needed to do something like that, that trauma surgeon's there and they're very well trained in that, and they can take them straight to the OR. Right now, what we would do is our ER doctor would have to perform the procedure, call general surgery. General surgery is probably going to say, no, like we can't. And we would then, in a very unfortunate case like that, we wouldn't really be able to transport that patient, and the likelihood of survival is very slim to none if that's what we have to do. But if it's like chest tubes and stuff like that we have to do, and it is survivable, then we would just the ER doc would do the procedures and we would transfer them to Desert Regional. Our general surgeons could jump in and do kind of what we call damage control surgery. If they need to open a belly and pack it for your liver, your spleen, they technically can do that. The nice thing is we have a very short commute, to Desert. So we could always kind of pack and go if we need to, send one of our nurses with the patient, giving them blood products and to get them where they need to go. And then we are always in very close communication. If we just recently had the motorcycle crash on the 10, where one gentleman went to Desert Regional and one came to us, and the one came to us was actually a full traumatic arrest. So he didn't survive, but I was in Denver at a conference and they called me, and I was calling Desert Regional from Denver. And I said, hey, Heidi, there's this patient. This is what's going on. We're going to do an airway if we need to. If we get return of spontaneous circulation, get pulses back, he's coming to you. She's like, great, I'll let the ER know. So we're in constant communication, and they were aware. And then our docs can call and talk to their trauma surgeons and keep updating. And then eventually will be even better, but it's a very fine-tuned machine once you get all the players involved. Yeah. Yes, sir.
Is there a plan to expand the ER?
That is the guy always. Yeah. We joked about that, and I said, oh yeah. The question was if there was plans to expand the emergency department now that we're going to see more volume, and as we advance our levels, we're going to see even more volume, right? I'm sure there's always talks about expanding it. I know Dr. Contaxis is always looking for where we can put new, open up beds. My dream world would be that eventually we would have a trauma tower that would be a trauma ICU, the floors where all of our trauma patients would be with our trauma resuscitation bays, and it would be an expansion of the ER, putting that out there in the universe. So, but right now, I think what they'll do is, we would need to see that consistent increase in volume to really make the point. But I know that the conversation, Kathy, I mean, ever since we were on the floor in the ER, they've talked about needing to expand that ER. Yeah. Adding, taking part of the lobby away and adding more beds and stuff like that. So, yeah. So, but it will, eventually, yes. What's gonna happen is we're just gonna realize we're busting at the seams, and we're gonna have to then see where we can move to make room for everybody.
Given the nature of the Coachella Valley, permanent residents and tourists, and then Highway 10, where do you see most of the trauma coming from?
So where do we see most of the trauma coming from to us here at Eisenhower, given our location? So I think that everybody knows that there's certain areas of the valley. There's kind of two areas that you see a little bit more gang violence and more of the penetrating trauma. Desert Regional is closer to one, Desert Hot Springs, and we're closer to some of the Indio, and we have the prison out and Beaumont, right? No, not Beaumont. Blythe, right? Is that the prison?
It's Mecca, I thought.
Yeah.
No,
But so my point to that is that I think that we'll start to see more of the trauma, penetrating trauma, stuff like that coming from there. But I think most of our stuff is going to come from the 10. We'll see Glamis with all of the off-road vehicles and the ATVs and stuff like that. A lot of those had to be flown either to San Diego or to Desert Regional. Those will start coming to us. We'll start seeing more, some of the 29 Palms accidents and injuries with the Marine base and stuff like that. Those would always go to Desert Regional, but it'll depend on, transport time. And just recently we had a patient brought to us because the roads were closed. So they couldn't get from Desert Hot Springs to Desert Regional. So they came all the way around and brought him to us, and it was a gunshot wound. So it really depends, I guess, on where the injury happens, but I would say we're going to see a lot more from the 10 than anything else. Yeah.
What's the level of John F. Kennedy?
What's the level of JFK? Currently, they are currently a level 4 REMSA. You have to petition the county when you want to go step up your designation, and they've already petitioned to go to a level 3, and they were given the go ahead to so the American College of Surgeons, you do a consult visit first. So they kind of come in and they do a mock survey and they say, okay, wow, you got all these things you need to fix before we come in and do the real one. And then they'll come in and do the actual verification surgery. So they verification survey. So they actually were given the okay to get their consult visit scheduled. So they'll probably be a level 3, maybe in a year or so. We'll be a little bit behind them, but the one thing that we will have on our, is that we have such a robust neurosurgical department that we'll be able to keep all of those. Because right now, that's when we were sitting there, we're talking about what they transfer out the most. They transfer every neuro patient out, and then they would be able to transfer those patients to us instead of having to go all the way to Desert. Even though they're sister hospitals, we would be the closest higher level trauma center.
Brett, do you have any questions at all?
Nope, we're good.
When you
Yeah.
talk about the aging population, the majority of the cases are fall
Uh-huh.
trauma. What about pediatric trauma?
So as far as pediatric trauma, where do they go currently? They would come to us or to Desert Regional for stabilization. So neither one of us are really a pediatric center. Desert has a peds floor. We have a peds floor, but it's more for like the, RSV kids that aren't really that sick. So we would stabilize and transfer to Loma Linda or to RUHS. But yeah, they would still come to us first. We actually get a decent amount of pediatric patients. We get some really, if any of them have any kind of cardiac arrest or anything that they come to us, and then we would transfer them to Loma Linda. Yeah, I worked in the pediatric ICU at RUHS for a while, and we got quite a few transfers from Desert Regional. So and now that once they start their pediatric trauma program, then it'll really just be kind of like who's got availability, who's got a bed, and where they go.
Let's give Brody a really nice clap.
Thank you.
You'll notice that Brody's a pretty good sized fellow, and he's got some pretty big ideas for the place too, doesn't he? Yeah, that's really good. It's really nice to have you here, and welcome back to the desert. We have actually good. So our second half of the program is going to talk about stroke. And tonight we have Kathy Cash, who's an RN here, been involved as an RN for 36 years, you told me. And yeah, she was worked in the ER for most of that time, and about a year ago took over the role of the stroke program coordinator here at Eisenhower. One of the interesting things, I asked her to give me a little bit of information about herself, and she wrote and she told me about her background a little bit, and I want to make sure I quote this perfectly because it's really cool. All right. So, she said here, she has a little dog. By the way, she has 3 children. She's married, and she likes outside and gardening and all that. But she's got a little dog, and his name is Archie. Okay. Now here's the quote, and I told her this tonight, that this is what she told me, that who is my favorite living creature. Now, honestly, I interpret that outside of not just a dog. I was wondering what happened to his husband or her husband there, but it wasn't. So, but you did say creature. So she's going to talk about stroke. And as you know, as heart patients, we're always interested in that. We have a lot of heart patients, and there's some of them in the room here, including myself, that have atrial fibrillation. And we're always concerned about stroke and that kind of stuff. And we're given blood thinners, those nasty things that turn us into purple people eaters and all those kind of things. So, excuse me, there's a purpose of that. So we're going to learn some more about stroke and what to do about it. So please welcome.
All right. So there's a lot.
You got to talk into this thing here.
Yeah, I'm pretty loud. So there's a lot to be said about, this for the Zoom audience.
Yeah.
A lot to be said about stroke. It's a very complicated disease, and there's a lot of components and moving parts to building a program and sustaining a program to take care of stroke patients. We actually are advanced primary care stroke center. We will eventually go into what's called comprehensive, and there we go. I just like people to see me. Eventually, but tonight I'm just going to talk about a little bit about stroke and then some risk factors. Oh, there we go. So this is my slide. This slide we've had around since the beginning of our stroke program. I've been involved in the stroke program since 2005. When we started doing PowerPoints, this is the slide that we picked, and I've kept it. It's actually from an old science fiction black and white movie that I watched when I was a kid. So you can't have a stroke talk without talking about what a stroke is. Basically, what happens with a stroke is that for some reason, the blood vessel that's going into the brain gets blocked, or it bursts, which we call a wet stroke, which is a hemorrhagic stroke, or the clot is a ischemic stroke. Atrial fib is called a embolic stroke, and that's where the clot somewhere in the body has gone up into the head and blocked one of the arteries. The other kind is where the clot, it forms in the, like plaque forms in the artery, and it closes off the flow to the brain. So what happens is the blood gets blocked, and then you no longer have oxygen or nutrients to the brain cells, and so things begin to die. These are just some stroke facts about how many Americans will have a stroke every year. And every 40 seconds, someone has a stroke. Every 4 minutes, someone dies from a stroke. And stroke is the 5th most common cause of death in the United States. It used to be the 3rd most common, but because of all the initiatives with the American Heart Association, the stroke correlation, it's dropped down to 5. Worldwide, 6.2 million people will suffer strokes each year. One thing is that strokes are preventable. So a lot of things about stroke you can prevent from having a stroke. So this here is signs and symptoms of a stroke. The key word is sudden. So if suddenly someone is normal and then they're not, like suddenly they can't walk, or they have their balance is off, or suddenly their eyes, they can't see, or they have vision changes, or suddenly their face is drooping, they can't smile, or they're slurring their speech, their arms are weak or numb, or they have a really severe headache. And most of the time it's a sudden thing, it's not gradual. So when that occurs, the most important thing to do is call 911, because the paramedics have protocols and they have things in place that they'll get going. They'll start an IV, they'll do a blood sugar, because a low blood sugar can mimic a stroke. So they want to make sure that. But the most important thing that 911 paramedics do is that they activate a stroke with the hospital. So what happens here at Eisenhower is the paramedics will call the MICN, as Brody was talking about, and let them know we've got a stroke. They give the information, and then we activate the code team. So we activate stroke neurologists, and we activate the ER, and we all gather together in one place. So here we go again, recognizing the signs and symptoms of stroke. Sudden loss of balance or uncoordination. Sudden vision changes, like if they can't all of a sudden can't see out of they can't see this side, or if they can't, there's something funny about their face, you can ask them to smile, and if you only see half their face going up, then that means that they've probably had a stroke, or something's happening. They're having an event, is what we call it. One arm is weak or numb, or their leg is weak or numb. Their speech is, something's wrong with their speech, or they can't recognize something, they're not sure what they're supposed to do with a meal. That can be a sign of a stroke. And then you want to call 911. Now, last time seen normal. This is important. We teach this in all the classes, and for the staff, the paramedics, is that the reason why the last time seen normal, last time the person was baseline, the way they always are, is because based on that time, we will decide how we're going to treat. So if you've truly had a stroke and it's less than 4.5 hours, we can treat with a clot buster. Currently, we're using a medication called TPA or Alteplase. Today, actually 2 days ago, we switched over to a new medicine that is simpler and quicker for the nurses to give, to shorten our door to drug time. That's a huge measure that we look at, data we collected all the time. And the reason why, so that would be the treatment. The other thing is within 24 hours of symptoms, we could actually take you to our IRL suite, interventional radiology. And we have specially trained radiologists that can go up and remove that clot. It's called a thrombectomy. And you can only do it within 24 hours. So that last time seen normal is something that you would want to, if you call 911 for a friend, a loved one, you want to be able to say to them, the last time I saw them normal was 15 minutes ago or 2 hours ago. So this right here is the progression of a stroke. So if a stroke occurs, so you have this right here, this red dot here, that's the stroke. So that's where the stroke, the clot has gone in here and the tissue is dying. The green part is the part that's called what we call the penumbra. That is the tissue that can be saved. And the longer we wait, the longer it will progress. So you see the little red, how it gets bigger and expands. So if no intervention occurs, then the stroke will just get worse. Tissue will die. The brain will begin to swell. And then things are bad. All right, so here's another picture, save the penumbra, time of innocence. So you hear the dead tissue here. Here's the main arteries of the brain, or some of the big arteries of the brain. This one right here is the middle cerebral artery. There's your dead tissue, and this is the penumbra. So a TIA is when something happens and then it resolves. It's not something to be ignored. Generally, if you had an issue, like you suddenly couldn't speak and you had right arm weakness, you would want to call 911 because it's a warning sign. Something's going on. So what would happen is you would come to the emergency room, call 911, you come to the emergency room. We would do the workup to see if you had a stroke or maybe you didn't have a stroke, and they may discharge you to follow up with your primary and neurologist, or if you have high risk factors, like if you have atrial fib or you have high cholesterol, there's a whole scoring system. They would admit you overnight to do some workup and observe you. They usually will go away, but it's a warning sign. And this is where you come in. You're the first link to the chain. Call 911. Don't wait. Don't drive yourself or have somebody drive you in, because the paramedics will stabilize you and they'll get you where you need to go. So EMS can transport by ground, we call ground, or by air to get you where you need to go. And they'll go to the closest stroke center. And all the hospitals in the valley are receiving stroke centers. Desert is a comprehensive because it's just like Brody's trauma thing, is that they have 24-hour coverage. They give the same kind of care, same quality care. It's just that they can offer 24-hour coverage, whereas we do a lot of what they do, but we can't offer 24-hour coverage. So prevention. So there are ways to prevent a stroke. Know the warning signs of a stroke. Choose healthy lifestyles that can lower your personal stroke risk. So this right here is an example of what we do here at Eisenhower. When patients are discharged, we give them instructions on stroke. We talk to them about calling 911. We talk to them about risk factors. We actually individualize to the person. So if you have atrial fib and you're on blood thinners, we talk about that. If you smoke, we highly recommend you don't smoke, because that's one of the biggest causes of a stroke besides hypertension. Hypertension is one of the #1 reasons why people have strokes. There are people that walk around that have hypertension or high blood pressure and don't know it. Usually it's because they never see a provider. They don't take their blood pressure on a regular basis. We're actually working on doing something different with the stroke discharge for patients. This is something, when I worked in the emergency room, I would work in what we call triage, where you interview patients and you'd say, do you have high blood pressure? And they're going, no. And I go, how do you know you don't have high blood pressure? Well, I don't take my blood pressure. I don't know how to take my blood pressure. I don't know what the numbers mean or what they are, and I never see a doctor or healthcare provider. My blood pressure is good. Why do I need to take my medicines? Hypertension, this is the final note, is a silent killer. So that's where some patient education comes in, community education, right? Be aware of your body, be aware of your symptoms, work with your provider, be compliant with your medicines. Yes, I'm on blood pressure medicines, but I don't take them. Do you take aspirin? I am supposed to take aspirin, but I don't take it. Those are the kind of things we hear. So a blood pressure, this is just a little bit about what a blood pressure is. The blood is pushing up against the walls of your arteries, and it's pushing blood through your body so that your body can get the oxygen and nutrients so it can function, and it rises and falls throughout the day. But if it's too high, what happens is it starts pushing against the artery walls, and that can cause it to thin and create plaque. So once again, people don't know they have high blood pressure until they start taking it. It's second to only cigarette smoking as a preventable cause of death in the United States. Hypertension, the definition is that your blood pressure is higher than normal. The higher your blood pressure, the more you're at risk for heart disease or stroke. Your healthcare provider can diagnose high blood pressure and make treatment decisions based on your readings and current practice guidelines. So we sometimes go out in the community and we take blood pressures, and a lot of times people will say, well, is that good? And we can't really diagnose or tell you one way or the other. We can just say, and we take it on both arms, a lot of times, because then you get people that say, that's not my blood pressure. And so we retake it. And we sometimes, it is, we're off. Health factors that contribute to stroke and heart attacks. Once again, high blood pressure, high cholesterol, high sugar. Maintaining a high sugar level is bad for the body overall. So that's why routine physicals, routine visits, routine blood draws, and if you are diabetic, be compliant with your medicine and diet. These are some core health behaviors related to stroke and heart attack: smoking, physical activity, diet, and weight. And by the way, since blood pressure is the #1 thing that causes havoc for people, strokes, heart attacks, all the other things underneath, like physical activity, a good balanced diet, no smoking, and maintaining your weight will help your blood pressure come down. Just physical activity. So here's some things that you can make a difference: measuring your blood pressure accurately, knowing your number, taking your blood pressure daily and record it if you have a history of hypertension. I tried to do that and I couldn't manage to keep it every day, but we're trying. My husband and I take our blood pressure every day, at least once a week. He takes hypertension medicine, so he should be taking his blood pressure. Follow your prescribed treatment plan, learn lifestyle changes that control blood pressure, recognize the signs and symptoms, and know when to call 911. Some resources that you can utilize is American Heart Association. They have a great website. They have a thing called BP, Target BP, and it's for the community. It's also for providers, and it talks all about blood pressure and different studies and different things about blood pressure. But they also, on the American Heart Association's website, they have a thing called Life Simple 7. And these are 7 things that you can do to help yourself stay healthy, keep from having a stroke or another event with your heart, maintaining activity, keeping a healthy weight, learn about cholesterol, what to eat, what not to eat, don't smoke, eat a heart healthy diet, keep your blood pressure healthy, and learn about sugar. This is our team. I joined the team. So I joined it last year. It'll be a year this month. Dr. Solari has been here for a long time. Dr. Clark joined about 5 years ago. And then we have Dan, who just joined our team, and then stroke, Nydia Torres and Grace. I spent most of my time in the emergency room as a nurse, but I was very active in the stroke program. I started helping build the stroke program in 2005. And then in 2009, we had our first certification, which we passed. And then ever since we've been involved. So now I moved into this after 25 years in the emergency room. I decided I needed to do something different. So there's just some references. Questions?